Good afternoon, everyone. Thank you so much for joining us today. I'm Melinda Bikini, the Director of Advocacy with the Cholangiocarcinoma Foundation, and we are joined by Isabel Gardette, who is Director of our Industry Engagement. And we are very fortunate today to have Dr. Funda Meric-Bernstam, who's the Chair of the Department of Investigational Cancer Therapeutics, the Phase 1 program, as well as the Medical Director of the Institute for Personalized Cancer Therapy at MD Anderson Cancer Center. And she's going to present to us today targeting HER2 and cholangiocarcinoma and gallbladder cancers. So Funda, I will turn it over to you. Thank you.
Thank you so much. This is really a pleasure to be here. And I'd like to touch upon several things today. I'd like to start off with disclosures. You know, many of you are familiar with this concept of showing disclosures, and you may wonder why we do this. And that's because really many of us are involved with a lot of trials, have relationships. And this is really just to make sure that you're aware that actually I am participating in a lot of clinical trials with several of the companies that I'm presenting data for, and also doing some preclinical research, trying to identify how we can treat patients better. And, we were talking about HER2 today because HER2 is really one of the best examples of personalized cancer therapy. You know, we talk a lot about personalized cancer therapy or precision oncology. And, as you know, this is because we realize that our previous algorithm of thinking of all cholangiocarcinomas the same really hasn't worked out to be very efficacious for us. And as we explored more the biology of the disease, we started to understand that using patient characteristics, such as germline changes, as well as tumor characteristics, what is happening in the tumor and what is driving the growth of the tumor, that can help us better understand the biology of the disease. In what scenario is the tumor more likely to relapse? Well, in what scenario is it more likely to grow faster? And in what case is it more likely to respond to one drug versus the other? And we often refer to these as biomarkers, prognostic markers that can determine outcome, or predictive markers that can help determine which drug would be better for our individual patients. A lot of what I'm going to talk about is related to DNA-based alterations. So I'm going to just get us all on the same page and do a quick review of genomics. As you know, DNA becomes RNA, becomes protein. You remember this probably from high school. And if anything can go wrong, it will go wrong. So there can be alterations in the DNA, mutations and copy number changes. There can be fusions, not as often in HER2, but you've heard about that probably for FGFR. RNA can have alterations, and there can be changes in the protein level of different important markers such as HER2. So with that in mind, there are genes that we refer to as oncogenes. Now we refer to them because these are genes that control the growth of cells. They control the survival of cells. And when there's something wrong in the DNA that makes that cell grow faster, that's where we think there may be a therapeutic opportunity for us to intervene. So things that are different in the genome that make either this oncogene more in the cell or make it more active, such as a mutation, is a scenario where we think we could potentially intervene. So in the case of HER2 that we're going to talk about, we know that there may be changes in the number of copies of the gene. As you know, we usually have 2 copies of a gene. And in the case of HER2, if there's multiple copies, that's what we refer to as amplification. And for genes that are oncogenes, if there's multiple copies, then that may confer the cells a growth advantage. That means that may be one of the reasons the cancer cell is more aggressive. And it may be an opportunity for us to intervene. Sometimes there's a mutation, and you've heard a lot about mutations in the context of other genes as well, probably, but sometimes there's a change in the DNA that leads to a change in the protein that's produced from it. And that's the fancy name we call for it is the non-synonymous mutation. But bottom line is this kind of a mutation, it can make a gene like HER2 more active. So we have known that HER2 is important in cancer cells for a long time. This is a slide, this is a figure that in a review paper I wrote. Note the date is 2006. I was a very junior faculty member then. And at that point in time, we were able to see that HER2 led to a lot of different changes downstream. And it was important in cancer cells moving around. It was important in cancer cells growing. It was important in them developing blood vessels. And it was helpful in the cancer cells surviving when we gave them, things like chemotherapy. And, this paper that I'm showing here is undoubtedly one of the most important, changes in outcomes in cancer biology that we've ever seen. When they noted that HER2 is overexpressed in breast cancer. And it really was a very big struggle to bring this into a drug that went into the clinic. There's actually even movies about it, which are very dramatic, I have to say. That eventually they were able to show that giving patients this antibody dramatically changed outcomes in patients that had metastatic breast cancer. And when these studies initially were presented, there were oncologists in the audience crying. I mean, about the differences we started to make in the outcomes of breast cancer patients. Since that time, we've learned a lot more about HER2. This is now a very well established target. There are drugs approved for breast cancer. There are different kinds of drugs. There are what we call monoclonal antibodies that bind Trastuzumab and Pertuzumab. And I think a lot of you have heard a lot about antibodies, especially in the COVID era now. There are small molecule inhibitors. These are usually pills that we give that can block the function of HER2. And we have three drugs approved in this space that are approved specifically for HER2-positive breast cancer. And there are drugs that are called antibody drug conjugates. There are antibodies that attach a protein, the HER2 protein, and then they have chemotherapy attached to them so they can release the chemotherapy into the cancer cell. So, thus you can see for breast cancer that's HER2 positive, there are several different treatment options for patients. For gastric cancer, now there's 2 drugs approved. Trastuzumab in combination with chemotherapy was already approved. And very recently, Trastuzumab deruxtecan, another antibody drug conjugate, was approved. Now, so we talk about HER2 being altered in patients, and you may be wondering, how do we detect these? Well, there's several different ways we can do that. We can look at the HER2 copy number a little more formally with a process called FISH. But in the clinical setting for cholangiocarcinoma, however, we don't often do FISH, though we could, of course. But what we do a lot more frequently, I think, in clinical care is next generation sequencing. I would argue that at this point in time, for all patients with advanced and metastatic cholangiocarcinoma, we should be doing some sort of a genomic profiling test. And usually these are able to detect at least higher levels of changes in amplification in HER2. In addition, genomic sequencing can tell if there's a HER2 mutation. That means, is there a change in the DNA that leads to potentially increase in activity of the HER2 protein? There are more and more companies that are academic institutions that are starting to look at also RNA levels in cancer cells. They're using a variety of different strategies, such as RNA sequencing or different technologies that look at a panel of RNA. These can also show whether the RNA levels of HER2 is increased, although I have to say that that technology is a little earlier in its development for clinical care, but it's definitely coming. Then finally, the HER2 protein expression, which is done using what we call immunohistochemistry, where we use antibodies against HER2, and we're looking at, is HER2 expressed on the cancer cell? And if so, what is the intensity? How much HER2 is expressed in the cancer cells? Now, when we talked about HER2 amplification, I already talked about the fact that HER2-targeted therapies are already FDA approved, both for gastric and gastroesophageal cancer and for breast cancer. But for some of these, we have limited lines of therapy. For breast cancer, we have several options, but still looking for more. But you can see that there are many other tumor types in which HER2 is actually amplified. And you can see that indeed hepatobiliary tumors are among those where we see HER2 amplification. In our group, and I run this, what we call a phase 1 program, but it's actually a investigational cancer therapeutics group where we're looking at early drugs in development. And we have a large number of clinical trials for targeting HER2. What we wanted to do is ask the question of, if patients are HER2 positive and they don't have gastric cancer and they don't have breast cancer, but they get HER2 targeted therapy, do they benefit from it? So this is really what we call a retrospective analysis, looking back at all of our patients we treated on a variety, usually on a clinical trial. And you can see that if a patient had HER2 positive disease and they got HER2 targeted therapy, they had an improvement. In progression-free survival, that means that the tumor was more likely to stay, not increase in size during the treatment. And this was a small study, but there was a trend, even an increase in overall survival. So this was very exciting and really encouraged us and highlighted that even drugs early in development where we're trying to figure out, is this effective for this disease? Clearly, HER2 is such a prominent target that it is, worth pursuing. Now, I want to highlight that HER2 isn't amplified everywhere equally. And, in fact, with all of our genomic sequencing studies in the last several years, we've really recognized that the biology of gallbladder cancer is a little different than extrahepatic hepatic cholangio, which is a little different than intrahepatic cholangio. So where the tumor arose may matter. HER2 varies among these locations as well. So a nice study, and I'm sorry, I forgot to put the reference, but there's a nice study from Memorial Sloan Kettering. They looked at 517 patients that had biliary cancer that had undergone genomic testing. And they found overall that a little over 5% of the patients had a HER2 alteration. 2.7% had an amplification, 2.3% had a mutation, and 0.4% of the patients had both alterations. It did differ depending on where the tumor arose, where, how frequent the HER2 alteration was. And in gallbladder cancer, it is more common, and it was 12.6% in their study. For extrahepatic, cholangiocarcinoma, it was 7.5%. And for intrahepatic cholangiocarcinoma, it was 2.2%. And they also accompanied this with a case report where they gave one patient on one of their studies, TDM1, which is an antibody drug conjugate approved for breast cancer, and they saw that patient responded, emphasizing that HER2, seems to genuinely be a target that's worth exploring further. So there's now several studies looking at how we can best target HER2, and several drugs in development or already approved, but we're trying to figure out the opportunities beyond breast and gastric cancer. So here's one study referred to as the My Pathway trial, which is a basket trial. You probably heard that term before. Basket trials are trials where a lot of different tumor types can enroll to get a drug in a scenario where that drug target doesn't have drug approval yet. So in this case, patients that don't have breast or gastric cancer were able to get Trastuzumab and Pertuzumab together. These are two antibodies approved for breast cancer treatment. In this case, you can see that there's really some activity seen in several different tumor types. And in this early report, you can see that there were some responders in patients with biliary cancer. More information on this study is coming. Now, A few weeks ago, I had the opportunity to present a poster at ASCO GI. I'd like to give you a little bit more detail about the data we presented from an ongoing clinical trial, which is looking at a drug, zanidatamab, ZW25, and I'm going to refer to this ZW25 going forward, which is a new drug that is a novel HER2-targeted antibody. It's what's called a bispecific antibody, which is a little confusing, I realize. The antibody binds two separate areas on HER2. It binds the area that it binds Trastuzumab, and it also binds the area that binds Pertuzumab. And the thought that two separate area binding may increase the tumor cell binding overall and may enhance the potency of the drug. And at this point in time, this drug has gotten FDA breakthrough therapy designation and fast track designation as orphan drug for second-line HER2 gene amplified biliary tract cancer. So we're very excited to tell you a little bit more about this drug. So in the trial we presented, this was a phase 1 clinical trial where we were looking at ZW in patients that had HER2 expressing cancers, including biliary tract cancer. Our goal was to determine, what is the maximally tolerated dose and what is the recommended dose? What is the dose we should be giving patients going forward? How safe is the drug? How tolerable is the drug? And how effective is the drug? So, and details about my presentation are shown here. This was abstract 299. So, the key eligibility criteria in this trial was that patients needed to have HER2 expressing cancer, and they should have gotten some standard of care therapy. In the case of biliary tract cancers, patients needed to be either HER2 3+ on immunohistochemistry or 2+ but have amplification by FISH. And we were looking at this in what we refer to as a central lab. That means we were getting a new biopsy to send it off to a lab so we can confirm before we start treatment that HER2 is genuinely either overexpressed or amplified. Patients had measurable disease. That means we could monitor whether the drug is working or not. And they had, what we call a good performance status. So here's what we did. We gave increasing doses of HER2 targeted therapies, ZW25, and then we followed that up with expansions, and we had a specific expansion of HER2 expressing cancers that included biliary tract cancer. So here, I'd like to present the data of the 21 patients with biliary tract cancer that were treated in part 2 of this study. So these patients got 20 milligrams per kilogram every 2 weeks. And this is a drug that's given IV. And you can see that, we had, a little bit of enrichment for female patients, and we had enrichment for gallbladder cancer patients, as you would expect. So 57% of the patients had gallbladder cancer, and then we had a special equal amount in intrahepatic and extrahepatic cholangiocarcinoma for the rest of the patients. You can see that there was a median 2 prior lines of therapy. That means patients had gotten other treatments before they went on this trial. And 5 of the patients had already gotten some HER2 targeted therapy. In these kind of studies, the first thing we look at is, how well tolerated is this? And I have to say that this is a very well tolerated drug. We had, very, very, only one patient that had, significant fatigue. And we had, overall, the 2 things that we're watching out for is that we have some diarrhea, but really very well controlled and usually very limited. And then we do have some what we call infusion-related reactions. That means the first time we give the drug, sometimes patients have a little bit of a reaction that's well controlled. But all of our patients are able to continue treatment, and we started giving some drugs to try to help that. That reaction that we see. So here's the exciting efficacy data that we see. of the 21 patients we enrolled, 90 of them were response evaluable. Now, I think many of you have seen these plots, but in case you haven't, I'm going to just tell you how we look at this. This is what we call a waterfall plot. So what we do is at the beginning of the study, we get a CAT scan or a study that captures what we call target lesions, and we do measurements of the tumor. And then we reassess how the tumor is doing every 2 months. So here you can see that we're looking to see, is the tumor decreasing size? And if it's decreasing size, you can see the bar graphs would go down. Or is the tumor increasing in size? And you can see that then the bar graph will go up. And if you have greater than 20% increase, we would call that progression. And if you get greater than 30% decrease, we're of course excited about that. So you can see that majority of the patients that were enrolled in the study actually seem to have tumor shrinkage. The other thing that we look at in these kind of trials is the duration of treatment. So, we start treatment, of course, on patients, and then, every 2 months we're reassessing to see whether they had a response. And it's hard to see, but if you squint, you'll see that patients that have PR listed, so those are the patients that had partial response. And then you can see some of the patients had a CPR listed, and those are the patients had confirmed partial response. That means not only did we do one scan, but in fact, we did a repeat scan and that we confirmed that indeed their tumor is shrinking. So you can see that several of the patients were really able to stay on study for a while. So overall, you can see on this table that we had a confirmed objective response rate in I can't read apparently, which is very problematic. But overall, we had a partial response rate of 40% in the study, which is quite impressive given the fact that this is monotherapy of a targeted therapy. There is no chemotherapy. So that's really, I think, very compelling. And further, the patients that had a response had a duration of response that was median 7.4. That means they were able to sustain that response for quite a while. So in conclusion, in this study, we concluded that zanidatamab was well tolerated and it had promising anti-tumor activity, especially in a population that had progressed after prior therapies, including some of them having had HER2-targeted therapies. It was well tolerated in that, most of our adverse events were either mild or moderate in severity. Based on this, this treatment is now going into a global registration-enabling study, and which I'll talk about in a few minutes. Now, I want to talk to you a little bit more about other HER2-targeted therapies that are in development. Here is one that, as I mentioned, is already approved for breast cancer, TDM1. It was approved for HER2 amplified breast cancer in the metastatic setting, and more recently has had, activity demonstrated in earlier line breast cancer settings. So that's very exciting. So in this study, what they did is it's a basket trial. And that means, again, patients, so this is two separate studies that I'm showing actually on the left-hand side and the right-hand side. You can see that there's been a little bit variability in what was seen with HER2-positive disease in different tumor types. But it's important to note that I had previously mentioned the paper from Mundaka et al., where I had forgotten to put the reference from MSKC. So here's that example where they were able to show that indeed a patient had a partial response with HER2-positive disease. That's important to note that, again, these were studies that were not bile duct limited, so but definitely shows signal that there may be activity in targeting HER2 with biliary tumors. Another different, antibody drug conjugate, again, an antibody that has a chemotherapy strategy, but a different chemotherapy that's in development is A166. And in in preclinical models, they've been able to show that in breast cancer models, for example, that compared to even with TDM1, that there's greater efficacy with this, with the caveat that preclinically, of course, it's hard to compare different dosages. So a phase 1 trial on the A166 was presented in 2019. This was presented at the AACR NCI EORTC meeting, and they reported on 27 patients that had a variety of different diseases, including 3 biliary tract cancers. In this case, they looked at the efficacy and toxicity in this study. And the safety showed that from a hematology, cardiac, and liver standpoint, actually, this was fairly well tolerated. One of the a little bit, more challenging side effects that sometimes happens with antibody drug conjugates is that there may be neuropathy or there may be eye toxicity. So these are the few things that they'll be monitoring. And clearly, at higher doses, these became a little more problematic. But this is, I think, an interesting drug because when they did the efficacy assessment, they found that they had really quite compelling response rates, with 44% of the patients having responses with one dose and 50% overall the patients responding in the other dose, with the caveat that the higher dose probably had some higher neuropathy as well as ophthalmic side effects. So overall, I think this is another interesting drug, and we'll see over the next a few years how the development of this goes. Another really interesting drug, I think, is the antibody drug conjugate referred to as Trastuzumab deruxtecan. So this is another, again, antibody that attaches HER2. This has a completely different chemotherapy than the TDM1 I talked about and the A166 I talked about. This chemotherapy is referred to as DXd for short. This drug is already approved for breast cancer and very recently for gastric cancer. In the drug development during the phase 1 trial, they enrolled a variety of different tumor types in their dose expansion, and the data from that trial was recently published. You can see that in that trial, again, if different tumor types are in different colors, but you can see one patient with gallbladder cancer, one patient with cholangiocarcinoma had really very compelling responses, and you can see the patient with the cholangiocarcinoma had quite durable response. So again, that's exciting in that it suggests that maybe this DXd payload is effective as a chemotherapeutic agent for cholangiocarcinoma and making it of interest for biliary tract cancer. And I'll talk about this again in a few minutes. So I talked a lot about HER2 overexpression, and I talked a lot about amplification, but let's talk a little bit about HER2 mutations, which are a little bit more confusing, I have to say. So HER2 gene could have a change in the DNA sequence in one of different areas of the gene. And remember that not every change in the HER2 gene, or any gene really, is necessarily going to activate the gene. And that's an important thing to remember, especially when you're reviewing a genomic report. So you can see when we look at what we call a lollipop plot, you can see that the number of patients that have different kind of mutations are listed along the sequence of the gene. You can see that there are a variety of different alterations that actually can happen in the HER2 gene. And if you look across tumor types, this has a little bit of a different pattern of frequency, but you can see that again, this happens. These HER2 mutations happen across a variety of tumor types, including amplification carcinoma, for example, as well, and hepatobiliary cancer. So suggesting again that this is not a very common finding, but may be relevant for a variety of different tumor types. So this is, HER2 mutations have been an area of great interest, and there's been a lot of investigation about what to do about HER2 mutations. One of the drugs that really got a lot of interest because it was a drug called neratinib. Neratinib inhibits EGFR, HER2, as well as HER4. And in lab studies, they had noticed that Trastuzumab wasn't very effective at HER2 mutations necessarily. However, neratinib as a small molecule was. So that led to a lot of studies in trying to figure out how it could be used for HER2 mutations. However, neratinib currently is FDA approved for breast cancer, not for mutations necessarily. It's approved for extended adjuvant therapy for HER2 positive early stage but higher risk patients. And it's also approved in the combination therapy with capecitabine for HER2 positive breast cancer patients in the metastatic setting. So a large international clinical trial was done to look at the role of HER2 mutations in treatment with neratinib. And given how rare this mutation is, of course, they really had to have a large number of collaborating institutions for this trial. And again, this was what we call a basket trial. So, and biliary tract cancers were introduced as one of the arms. When we did the very first report of this study in 2018, you can see this is what the waterfall plot looked like. It's very colorful. So let me just take you through it. You can see that in some diseases like breast cancer, there's quite a bit of activity. And there's a couple of diseases we're watching, such as cervical cancer. We had, a little bit less data on biliary cancer at the time of this publication. So last month in ASCO GI, Jim Harding reported the updated data on biliary cancer. And you can see that, they enrolled patients with gallbladder cancer, cholangiocarcinoma, and ampullary cancer that they're reporting here. And these different colored spots in the bottom are actually different kinds of mutations that were reported. While this color code section here are the overall responses of the patient, so partial responders versus stable disease. So you can see that there were actually partial responses in patients with both cholangiocarcinoma and gallbladder cancer. So overall, in the study, the objective response rate was 16%. And this was, the duration of response, however, was a little bit less limited. So that you could see that for each responder, it ranged from 3 to 4.7 months. That means patients did respond, but unfortunately, the tumor was a few months later, 3 to 5 months later, started growing again. So I think there's a signal here with neratinib as well with HER2 mutations, but it suggests that maybe we could do better with combinations. So that's something we're actively exploring. And this is the best response and duration of response, what we call a swimmer plot. Okay, so the one other thing that I just want to mention about neratinib is you can see that each drug that we talk about actually has a different side effect profile, which is interesting. So in the case of neratinib, what we talk about mainly is the potential of diarrhea. So there is known to be some diarrhea that occurs, especially when we start off with the treatment. So actually, we give patients what we call prophylaxis to try to stop diarrhea. So I had already talked about antibody-drug conjugates, and we always think about antibody-drug conjugates as being effective for patients that have HER2, a target expression or amplification. It was really interesting, because an interesting study showed that patients with HER2 mutant lung cancer actually could have a response if they had an antibody-drug conjugate towards it. In this case, it was originally reported with TDM1. And that was a really interesting study, I think, which showed a partial response rate of 44% and really led to this whole change in thinking about the role of HER2 mutations or any mutations really in ADCs. The Trastuzumab deruxtecan ADC that I recently talked about was also looked at in early studies. And you can see that there are also patients in the early clinical trials that I'm marking with arrows in red that had responses that had a mutation but didn't have HER2 expression. So that suggests that indeed in HER2 mutations, this may be an interesting strategy. So one other alteration I'm going to talk about is really not commonly talked about in cholangiocarcinoma, but I think since I'm in a biliary, pancreatic biliary run, I'm going to talk about this briefly. There's a fusion in a gene called NRG1. This has been relatively recently recognized. It's not very common, but it's found in pancreatic cancer in 0.5% of the patients, gallbladder cancer in 0.5% of the patients, and not all fusion tests actually look for NRG1, but when it is found, this is really a very compelling target and definitely worth, I think, seeking out. So this is just sort of a sharing for completion. So I want to just start wrapping up a little bit slowly by talking about ongoing and upcoming trials in HER2-positive biliary cancer. So I had mentioned the ZW25 phase 1 data to date. That led to the current registrational phase 2b trial that is designed really to look at the activity more formally in advanced or metastatic HER2 amplified biliary tract cancer in the second line or later. This is also called the ZW25-203 trial, and this is the clinical trials information here. And this was presented as a trial in progress at ASCO GI by my colleague Subham Pant. So the objectives of this trial is to evaluate the anti-tumor activity of ZW25, look at safety and tolerability, and learn a little bit more about some of the biomarkers and its effect on quality of life. And so it's a very exciting trial that is going to be enrolling 100 patients with HER2 amplified biliary cancer, and and every 8 weeks, patients will be getting scans like we did in the phase 1 trial. And the primary endpoint of the study is objective response rate, hoping, of course, that we would have compelling response rates like we did in the phase 1 trial. The eligibility is to have a confirmed biliary tract cancer, either histologically or cytologically, including gallbladder cancer, as well as cholangiocarcinoma. This includes, locally advanced or metastatic or not eligible for curative resection. Patients must have progressed after treatment with a gemcitabine-containing regimen, or alternately have been intolerant to the most recent prior therapy, and they must test positive for HER2 amplification by in situ hybridization assay at a central lab. They must not have received prior HER2-targeted therapy. This is a large clinical trial, and it's currently active and accruing. It's accruing at my institution at MD Anderson, and it's accruing in many countries, all shown in purple. And also, it's planned to open in several other countries, including Canada, Chile, China, Spain, France, Italy, Korea, UK. So it's I think it'll be a great international collaboration. So I want to talk about a few other trials that are ongoing that I think that are interesting. I had talked about Trastuzumab deruxtecan. That has a clinical trial ongoing now. That's a basket trial that is also looking for biliary tract cancers as one of the diseases that they're recruiting. This trial is looking for HER2 expressing patients. So it's looking for HER2 IHC positivity. Prior HER2 targeted therapy is allowed. Here, the primary endpoint is going to be objective response. Again, this is looking for advanced or metastatic disease. HER2 expression needs to be, can be determined locally or centrally. Patients need to have what we call measurable disease that can be assessed. I think in this particular trial, HER2 mutations alone is not eligible, but I'll tell you in a few minutes that there's a separate HER2 mutation trial ongoing. And then a few other trials that are ongoing are trials with monoclonal antibodies. Pertuzumab, Trastuzumab, I already talked about the My Pathway trial. That has already closed, the biliary as a trial. However, the Pertuzumab, Trastuzumab regimen I mentioned is still available through the ASCO taper trial that has a specific cohort of that allows for biliary tract patients to enroll. Antibody drug conjugates. I had talked about trastuzumab deruxtecan, the Pan Tumor 02 trial, which is for HER2 overexpression. There's also a Pan Tumor 01 trial that's enrolling HER2 mutations. And then an antibody drug conjugate RC48 for HER2 overexpressing metastatic biliary tract cancer, which is accruing in multiple sites in China. And TDM1 for HER2 mutations through Tapestry. And then for HER2 mutations, there are several other small molecule inhibitors in development. A few of those that are ongoing include Positinib for HER2 mutations and BDTX 189. And then, before as final sort of words, I just want to point out that I touched upon mainly, monoclonal antibodies, small molecule inhibitors, and antibody drug conjugates. But there's a whole field of immuno-oncology also developing for HER2. There are T-cell engagers. There are a variety of different ways to try to enhance the immune system, leveraging the HER2 positivity of tumors. So that's going to be a very exciting area over the next couple of years. And finally, these kind of studies are hard to do and really requires teamwork within institution within the country and all across the world, to be fair. But here I just like to acknowledge at MD Anderson our biliary cancer working group, as well as our HER2 working group, and our Department of Investigation Cancer Therapeutics, and all my great colleagues in that. I'd like to wrap up and say I'm happy to talk to you with any comments, collaborations, and questions.
Wonderful. Thank you so much for your presentation. There are some questions that came in, but first question I want to ask is, will you explain, is HER2 and HER2 the same, or is there a difference? People always don't know that, that it is.
Yeah, so first of all, let me just say that when I say HER2 is amplified, I'm being a little sloppy. In reality, if I'm writing if you're writing a textbook and you want to be accurate, the gene name is ERBB2, and the protein is HER2. And we're very careful about that for most other genes, but in reality, I think a lot of people refer to HER2 throughout. So thus I refer to as HER2 amplification, but in many genomic reports, you may see this as ERBB2.
Correct, and that's where I think patients get confused. They're like,
yeah,
I don't have HER2, I have the ERBB2.
Yeah, so that's a great question. Thank you for letting me clarify that.
Okay, let's see. What is the difference between drugs that target HER2 amplifications and those that target HER2 mutations?
Thank you. So first, there are differences in that there are drugs that are in development, and for some we think they may be more active for some things, for the other. For some we really don't know and we're learning. So as I mentioned, for example, Trastuzumab, which was originally approved for breast cancer, and we weren't quite sure if it's going to be as effective for mutations. So for all of these drugs that are in development, we are testing to see, will it be as efficacious for mutations as it is for overexpression amplification? The idea that HER2 is overexpressed amplified was an early recognized finding. In fact, there was a very early finding about HER2 mutations in rats, but nobody really followed up on it. In humans, we noticed that in breast cancer, HER2 was amplified or overexpressed. That led to that entire field focusing on that. Only when we started doing more recent genomic sequencing did we realize that this HER2 mutation happens. It's not very common, but as we do it more and more, it became more. We were more capable to do trials in the space and ask these questions. And just to give you a perspective, when these trials, like the Summit trial for neratinib, started, not every institution was doing genomic testing, and not every patient was getting genomic testing. The situation is very different now. In like diseases like cholangiocarcinoma, there is an FDA label for FGFR fusion. I mean, you need to be doing genomic testing. So that alone, the fact that there's an already approved agent needs to push you to, as a standard of care, learn.
Yes.
And then the rest is still more exploratory. But I would say of all the alterations we talk about, HER2 is one that really is so compelling that you really need to act on it. When I see a genomic report and I see HER2, I smile. So
Yeah. Well, good, because I do have that mutation, so that's my backup plan. So keep working, keep doing the research. So if one has had biomarker testing multiple times, genomic on the tumor over 7 years and from various tissue, lung, liver, and no results have showed or revealed HER2, is it possible for it to express later on?
that's a really excellent question. So we do know there may be changes in tumors with time. So I do have to say that my gut feeling is things that are there from the get-go are probably really very strong drivers, and they may be more compelling things to act upon in general. But we do know that in colon cancer, we've seen, for example, HER2 can emerge as a resistance marker to other treatments that have been given. And similarly, HER2 mutations have been reported for patients that had HER2-targeted therapy in some other, in disease like breast cancer, although not very common. So I'm going to guess that, when you're looking at additional testing, it's always worth thinking about what is the added value of this? Are you doing broader testing, or do we think the tumor genuinely changed in one way? I do believe that if you got targeted therapy and the tumor biology has changed, you responded and the tumor is now growing, it's worth thinking about retesting, either with a repeat biopsy and genomic testing or with a liquid biopsy, because something made the tumor start growing again, and it may be something that we can target. But on the other hand, I think it's less likely for HER2 amplification or mutations to emerge in that setting and then be responsive in every cell in the body when we treat it, because it probably is, driving the growth of some of the metastases.
Okay, thank you. So I cannot pronounce these drugs, but the drugs that are in the My Pathway versus the ZW25, you mentioned ZW25 binds same sites as the two individual drugs. What might be the advantage of ZW25? Did you mention improved binding?
Yeah, so that's an excellent question. And to be fair, these are hard questions to answer. And I think that there'll be other data coming out from the lab and the folks that made ZW25. But at least the hypothesis is that if you bind two separate sites, there may be greater internalization. There may be other sort of multiple different additional mechanisms that may be unique to this. So I think ultimately we'll see with time what the activity is, with these different treatments, and that time will tell. The biliary tract data from other strategies I think are going to be emerging over the next year or so. But I think the response rate in the ZW25 biliary tract patients in our phase 1 trial is really, really very compelling, especially taking into consideration that this was very well tolerated.
Okay, good. This question is, does MD Anderson have partnership with international Australia researchers where they are exploring melittin derived from honeybee venom as HER2 treatment?
Yeah, so we have collaborations across countries, and we do have even global academic program partnerships where we have regular meetings together, et cetera. But I have to say that my only knowledge about the honeybee venom is what my dad told me about. So I have not done a deep dive investigation in this realm, but sounds interesting. Okay. So, but of course, some things look very good in the lab stage, but a lot of work goes from that point to actually, into the clinic.
Okay, so follow up on the other one. So does it seem that HER2 overexpression results from HER2 mutations?
Yeah, so that's an excellent question. So no, I think it's common for HER2 amplification to cause overexpression. So I'd say most tumors that have multiple copies of HER2 also overexpress HER2. That's of course relevant to think about, because if you're considering a HER2 overexpression trial, and you're HER2 amplified, that's relevant. We don't know how often a HER2 mutant tumor is also expressing, or how much they're expressing. And those are the things that actually we're trying to systematically do. And but of course, the HER2 data, for example, with antibody drug conjugates, were even more surprising for that reason, because we expected that you need to have expression for the antibody drug conjugates to work. But it's also important to know that some of these tools, like immunohistochemistry, where we're looking at protein levels, are somewhat crude, and we may not be as sensitive in telling whether HER2 is expressed or not. And now we're starting to realize, with new drugs that are more active, that we need better ways to assess how much HER2 is expressed.
Okay. So if a genomic test showed the ERB2, HER2, and EU in parentheses as negative 50% and not amplified, is this important in my profile?
Oh, I'm sorry. I missed the beginning of this. So is it not amplified, or is it amplified?
Not amplified.
Yeah, so if it comes back as not amplified, then it's kind of like not having that as a driver. So, so one of the things we're doing when we do genomic reports is we usually report what is actionable. That means, of these genes that we think that we can target with drugs that are currently either approved or in development, do you have something in a gene that's actionable that changes the action of that drug? Of that gene. So when they say HER2 is negative, then that means that's something that that's not a path we will be pursuing in that setting.
Thank you. So if a CC patient has a family history of breast cancer that's HER2 positive, is there anything they should watch for besides having molecular profiling done?
Yeah, thanks. We don't necessarily know that HER2 positivity is related to family history. However, breast cancer, as you know, can have a link to biliary cancer, in that, breast cancer patients, if you have family histories of multiple breast cancer patients in family, ovarian cancer patients in the family, or early onset breast cancer, there may be alterations in genes like BRCA that may have a role therapeutically, as well as for development of biliary tract cancer. So I think that's important to relay. Some of the genomic testing we do today for treating patients include germline testing. So some companies actually say, do you want germline testing? But some don't. And for example, if you get a genomic report and you see you have a BRCA mutation and they only tested tumor, actually it's important to go back and get germline testing, because it actually may be a germline finding and relevant for your family members as well as your treatment choices.
Okay, thank you. When a patient is found to have several mutations, how do you determine which is a driver and which is a passenger?
That's an excellent question as well. So first, let me say that if there's many mutations, that's another really interesting thing, because we now know that if we have multiple mutations, that's a scenario where we call tumor mutation burden is high. And that has implications for immunotherapy. And there's already approval now for PD-1 inhibitors for immunotherapy for patients that have 10 or higher mutations per megabase. So that means if you have a genomic report and they didn't assess your tumor mutation burden, that's something worth discussing with your physician to see if there's actually immunotherapy related sensitivity opportunity. Outside of that, when there's multiple mutations, a little more complex, because some of these mutations may not be a driver, and it also depends on who did the sequencing and how they report this. But if you have multiple genes that we think are drivers, it makes the treatment more complex, and it may decrease the efficacy of some of the treatments. We don't know as much about different genes and HER2-targeted therapy. However, we know, especially in biliary cancer, but we know more in other tumor types. So, for example, last year I published a paper on HER2-targeted therapy in colon cancer, and in that case, we found that KRAS mutation conferred resistance to Pertuzumab, Trastuzumab, and their objective response rate for no mutations in KRAS was substantially higher. It was 40% versus 8%. So thus, what other things are mutated in the protein in the gene is important. In the tumor is important. So we need to think, the big picture of what else is driving the tumor, and eventually, I think we'll be able to understand whether this will affect our treatment choices and whether one drug is more effective in the setting of other gene alterations or not. So that's information we want to continue to gather.
Okay. And have you seen successful combination of HER2 therapy with immunotherapy for cholangiocarcinoma? And are there any promising therapies for ERB3? Excuse my dog.
So I think we're still learning about HER3 as an opportunity. And I think the idea of combining therapies is definitely an exciting one, especially with immunotherapy. But again, it's a little early for that yet. So I'm hoping next year I can give you an update on that.
Okay, good. Let's see. Are tumors that are HER2 mutated targeted in the same way as HER2 amplified tumors, or do you prefer certain drugs in one niche and other drugs in the other?
I do think there's differences in sensitivity, and for some drugs, we don't have that information as well at this point in time. But we're constantly trying to gather that information of what drug is most effective in what setting. And in some trials, we just need to look back to see if we're enrolling for HER2 amplification or HER2 overexpression, did the mutations matter? While in other cases like HER2 mutations, we usually do standalone trials trying to look for that question, trying to understand what is most effective in that setting.
Okay. And do you know if there have been any responses to biliary tract cancers in the ZW49?
I actually I'm not involved in the 49 trial, so I'm unable to comment.
Okay. Hello from France. How often do you recommend to do blood testing? I had one in June 2020 with no possible, not sure what the word is. When should I try again?
Yeah, so it's a really great question to see when is it worth repeat testing. So again, I do think it's worth doing at least tissue testing once, and then if the tumor responds and especially if you've had targeted therapy, and then if the tumor responds or you have prolonged stable disease and the tumor then comes back, at that time it is worth considering either repeat tumor testing or liquid biopsy. I don't know that intervening chemotherapy means we need to get continuous liquid biopsies. So we're now trying to understand the value of extra testing, trying to make sure that we're also being thoughtful about resource utilization in healthcare, while simultaneously trying to make sure we learn as much as we can to treat our patients effectively.
Okay, a couple more questions because we're about out of time. There's a few more. Can someone with cholangio that has had genomic somatic testing done and thus far doesn't express the HER2 protein or BRCA gene, is it possible for the gene to express or result in germline testing?
I'm sorry, can you repeat the question?
Yes, so someone with cholangio that has had the genomic testing done and does not express the HER2 protein or the BRCA gene, is it possible for the gene to express or result in germline testing without seeing it on the genomic testing?
I want to do a few clarifications. On genomic testing, we don't really see expression. We only see amplifications or mutations. I'm not aware of germline events for HER2, so I think that's rare. There's definitely germline mutations in BRCA, however. And I think if there's a family history that compels you to do genetic testing for genes like BRCA, that should be done even if the tumor testing didn't show anything, because tumor testing is not designed to do genetic testing, and they don't, and things can be missed that way.
Okay, and we are right at our time, so I just want to thank you very much, Dr. Meric-Bernstam, for presenting for us today. We learned a lot, and if we didn't get to your questions, I will look them over and see if we can get answers for you. And thank you, everyone, for joining us today. Thank you so much. Take care. Bye-bye.